Be here at the PA Hospital with Greg, one of our nurse navigators, and the State Secretary of the Queensland Nurses and Midwives Union, talking about a report that was published this week from Central Queensland University, and it's a Queensland Health Nurse and Midwife Navigator Evaluation Report. And what this report showed is the independent evaluation of the benefit of nurse navigators. In 2015, the Palaszczuk government committed to engaging and employing nurse navigators across the health system. Today, we have 405 permanent nurse navigators working for Queensland Health and our hospital and health services. What this evaluation has shown over a 48-month period up to the 2021 is over 7,000 navigated participants. It has saved us per annum $110 million. Now, it has done that by reducing ED presentations, reducing emergency department stays, reductions in failed to attend episodes, inpatient admissions, reduced the inpatient length of stay, and also decreased readmissions. So as much as this is a huge saving for the health system, and so the cost-benefit analysis absolutely stacks up, most importantly, it improves the healthcare and quality of life of these patients. Now, we know nurse-to-patient ratios work. We know that it saves lives and improves healthcare. But now we know that making sure that our nurses can work to top of scope, so whether you're a nurse practitioner, midwife, a nurse navigator, it's utilising those full skills. We know that navigators help patients navigate the system, because we know that people failing to attend appointments, who fail or who get readmitted regularly because they're not managing their medications, not making other appointments, that when they reach barriers, they stop looking after their health, and having someone qualified to help them navigate through all that, we knew would make a difference, but now we have an independent evaluation from CQU that confirms that. What this report shows over just 7,000 patients is we had a 1.7% decrease in discharges against medical advice. So these are people who are advised not to leave hospital but discharge themselves, and that was reduced down to just 0.2%, which is incredible. 5.7% reduction in failure to attend appointments, a drop in the length of stays by average of 3.2 bed days per patient, a decrease of readmissions, which we know is really important, by 6% across those patients. And we know it saved around $3,300 per patient per annum due to the outpatient appointments being organised. So this is an incredible confirmation that nurse navigators make a difference. Now, we've just heard out of National Cabinet around the Medicare Task Force report that one of the important elements is making sure that all of our health professionals, whether they're doctors, specialists, nurses, pharmacists, are all working to their top of scope. We know that this can make a difference. We know that we need to find alternate solutions to the pressures that our health system is facing right now, and nurse navigators are just one of those solutions. And out of the work that we've done around our Health Workforce Summit and the strategy that's being developed, these are the sorts of things that we're looking at to help deliver health care to Queenslanders no matter where they live. I'll now hand over to Beth, and then we'll hear from Greg, one of our nurse navigators.
Thank you, Minister. I'm really excited to be here today on the day that they've released the Medicare Task Force report to demonstrate the difference that nurses and midwives can make to our health system. They're an untapped potential, and as the Minister said, they're not working to their full scope right now, be they registered nurses, registered midwives, nurse navigators like Greg, nurse practitioners. We have got a fundamentally fantastic resource in our nurses and midwives that can do so much more than they're currently doing. After all, we've got so much pressure on our system that there's more than enough work for everybody to be doing right now. And the report that's just been released today through National Cabinet demonstrates that Medicare, it's almost 40 years old, next year it'll be 40 years old. Has been fantastic and it's served us well, but we need to reimagine it. We need to reimagine it with new roles, working importantly in the community. They can't be hospital-based. We need to be getting our nurses and midwives and other health workers out in the community and delivering community-based services to keep people well and out of hospital. And that's the sort of job that our nurse navigators do day in, day out. As the Minister said, for only 405 of them around the state, they save $110 million per year in savings that can go back into hospital services, but also into services to prevent illness in the community. So we're very excited and we want to see the potential for this role to be rolled out elsewhere across the health sector, and we're hopeful that the federal government will be providing some funding to enable that to occur. It's not only nurse navigator roles like Greg's, it's also nurse practitioner and midwifery continuity models. We need to actually change the way we think about healthcare though. We all want more funding and there's never enough money to actually keep all of the services going, and that's really important to have appropriate funding. But we need to be changing the way we think about healthcare, and that means that we need to be collaborating and letting everybody work to their top of their full scope. We don't need to have gatekeepers. We need to have people who are gate openers, and that's what nurse navigators are. They navigate patients through the system, they help them through the system, they deliver better outcomes, and they actually save the system a hell of a lot of money. So we're very excited to be here today at the launch of this report, and we thank the Palaszczuk government for investing in nurse navigators, because we lobbied for this role before the 2015 election, just as we had lobbied for nurse-to-patient ratios, and they are delivering fantastic outcomes for the community of Queensland. And we'll now hear from Greg, his first-hand experience about what he's delivering day in, day out. Thank you.
Thank you, Minister. Thanks, Beth. Yeah, thank you. Thanks for letting me come here today and talk about being a nurse navigator. I think it's such an important and vital role that we get to do. It means that we get to break down some of the older kind of silos of care, so that now the hospital will go with the patient back into the community, and we can make sure that their care in the community is optimised and is going to be meeting their needs as best as possible in the home, which is good. It's such an important role. You get to work really closely with GPs as well, and just help make sure that you get a good outcome for patients. So an example of a success story that I've had is I was contacted by a GP who had a patient who was taking too much Panadol for back pain. So his back pain was bad, so he thought, you know what, I need more Panadol, that is good for me. But through working with the patient and being in his home and getting to know him, I was able to work out that actually his bed was causing a lot of his back pain. So through contacting some community organisations, we were able to get a new bed arranged for him, which means that he's now on a very normal dose of Panadol and he doesn't have back pain anymore, which means that we're not going to see him in a few years here in the liver clinic with the side effects from having Panadol. So I think it's an amazing job, an amazing position. Yeah.
Can I ask you,
Yeah.
you mentioned that midwives and nurses were doing a lot, but they could be doing more. What more could they be doing? What sorts of things practically can they be doing that they're not now?
Practically, they can be doing the role that Greg is doing, better coordination of care to keep people well. And importantly, we need to be expanding nursing midwifery roles in the community, closer to people's homes, so we don't have so many people coming to emergency departments. We know the pressure there is on primary health care right now, that it is crumbling under the pressure, that bulk billing rates are absolutely plummeting. People can't afford to go to their doctor, so where do they go? They come to their nearest public ED. But nurses and midwives can work in multidisciplinary clinics. In the ACT, for example, they have 6 urgent care clinics that are run by nurses, and nurse practitioners run those clinics. They are absolutely delivering excellent outcomes, but they're removing pressure from the emergency departments. So we need to be reimagining our health services and how they're all networked in together. So much more of the services need to be delivered in the community, closer to people's homes. And most importantly, the person needs to be placed at the centre of the design. We need to be doing much more co-design, and it needs to be place-based. Every hospital and health service, every community is going to be different in terms of what services they need. So we need to be designing those services with the community so that they're delivering the best possible care to them to keep them well, rather than just focusing on treating the illnesses when they're in hospital.
Would you like to see more of a solid outcome from national National Cabinet today. Obviously, these are big discussions to be had. There's been a lot of reaction that the next time this will be considered is April. Do you want to see things moving a bit faster in terms of a funding commitment?
We will continue to lobby for roles like nurse navigators across the whole of the community. I said on radio the other week that we've got 405 of them now. We need 4,000 of them in Queensland alone, is my estimation. Think how much money that would save the system. Not only employed by Queensland Health, but employed in primary healthcare and other settings. So yes, we're really keen to actually see things happening on the ground. And I'm sure that it'd be great if the state governments and federal governments can work together. I know the Minister will be talking to her federal counterpart about that, how we can reimagine services. Because as I said before, Medicare is almost 40 years old and it was fit for purpose, a few decades ago. It's not anymore. Healthcare is fundamentally needs to change, and we need to be offering services across the divides of federal and state government. As you know, the federal government funds primary health care and aged care, state governments and half of public hospital funding, or not quite half of public hospital funding, Minister. But we've got to absolutely not have the funding models driving the design of health services. And so for too long, it's been a bit of a fight between who's funding what. We need to be reimagining how we're absolutely delivering services and making the funding models meet the new models of care.
Should we have had these discussions 5, 10 years ago before we got to this point?
I think there's always, I think it would have been great if we could have had this discussion, but we didn't have a willing ear, I've got to say, to be having this discussion 5 or 10 years ago. We're always keen for reform. We can't stand still. We have to be doing things very differently. I mean, many years ago, nurses, for example, weren't allowed to take blood pressures, right? So the world moves on, and the world has moved on in the last 5 or 10 years significantly. So we will always be changing, and with the growth in population in Queensland, that's so significant. We've got a very big growth corridor between Metro South and West Moreton, for example, where we're going to need new services in those communities where there's going to be population growth. So we've got an opportunity now. We should be taking the opportunity and really focusing on multidisciplinary team care out in the community that hasn't got the barriers that are based on funding, that we're absolutely just focusing on the care that needs to be delivered and that the funding is seamless to support that.
Minister, with the National Cabinet and with Medicare, the federal government is yet to commit to going back to that funding arrangement that we saw with the states during COVID. Is that still what you're pushing for?
So we'll continue to have those conversations with the Commonwealth. I'm eager to see investment in primary care as much as I am in the public hospital system, because if we get it right in the community, then that helps ease the pressure in our hospital system. We know that it's like investing in primary schools takes pressure off high schools. Early intervention, prevention is the key, and that is about the community. Now, as Beth said, we do a lot of outreach, and we've done a lot of outreach in the last few years, and particularly since COVID and beyond, to try to keep people out of the hospitals. We've had, and you've all heard me talking about aged care residents in our hospitals, and we get a lot of transfers from aged care. So instead of waiting, and I welcome the Labor government's commitment to the nurse ratios in aged care, that is going to make a huge difference. That's a game changer. We know it's a game changer. But until that happens, to try to alleviate all of those ambulance transfers and all of those long stays in our hospital, we're doing outreach. We're sending our nurses into aged care centres to overcome some of those issues. Now, yes, that's nurses I need in our hospitals, but we also know the benefit that creates, because that frees up beds for us. The mental co-responder model. Recently when I went on a ride along with some of our paramedics, the station said to me, look, we have this person that we see almost weekly, and every time we pick that person up, we transfer them to RBWH. And when they turned up in the last few weeks and said, so are we going to RBWH today? That person said, no, I don't need to be transferred. And they said because the mental co-responder person came and visited them in their home the previous weekend and worked out a plan for them, and they feel stable. That is the first time that station has ever had that person say, no, I don't need to go to hospital. It's one person, but one by one we are making a difference, and we're diverting people away from our hospitals through a whole lot of initiatives, including what Greg's talking about. Greg looks after people with disabilities and helping people with disabilities navigate the system. As simple as the bed was the problem. It's things like that, but you can't find out the bed's problem if all you're doing is treating the symptoms at the back end and actually not stopping and looking at the whole situation. So to actually look at someone's holistic care, and this is why we need to work with GPs, and they are key to the solution here. Our GPs delivering holistic care when someone comes in who's elderly and overweight with a sore knee, looking at them and going, let's do a plan for your diet and your exercise and other issues. That way we won't be doing a hip replacement and knee replacement, and you won't end up with diabetes and you won't end up long stay in a hospital. That sort of holistic care at the GP level and working with nurse practitioners and nurse navigators will take an incredible amount of pressure off our public health system.
Minister, can I ask you about the payroll tax? There will be a reprieve, an amnesty, a pause, whatever you want to call it, but the Pharmacy Guild has said, well, we would hope that that would mean GPs don't put their prices up over the next 2.5 years. Is that fair? They don't have to pay this tax?
I think it's fair. If there was an amnesty on them paying the tax for the 2.5 years, I don't think that there is a legitimate reason to say they're putting it up because of this. Now, if they're putting their fees up for other reasons, that is their prerogative, and that's them to explain to their patients. But you couldn't say we are needing to put up our prices for our patients because of this tax that they're not paying. So, you know, that's, and I welcome Treasury working with the peak bodies who represent doctors to find this solution. I think it's fair and reasonable, and it acknowledges that there is an issue here as a consequence of recent court rulings that we need to work through.
The AMAQ says that doesn't go far enough in terms of this reprieve. They don't want it to be chased up for this tax at all. Would the government consider an indefinite?
But there's lots of medical practices out there who are not liable for this tax because of the structure that they have in place. This is giving 2.5 years to look at the structure of their business and, as the Treasurer said, decide whether they can set up their business so that they're not liable for this tax, or alternatively, if they do want to run their business as an employment arrangement, then consequently working out how they're going to generate the income for that. But if you run a business that is an employment arrangement, like every other business, you pay the tax. But 2.5 years to restructure your business so that you're not liable for the tax is a good solution.
Did the threats, and there were threats that patients would be paying more, particularly people in aged care, they've been through so much, the cost of living's going up. Did the threats work, I guess? They've been threatening all week that patients would bear the brunt of this tax. Did that cut through with the government?
Look, what it shows is the Palaszczuk government is listening to the GPs and the peak bodies, that this ruling that came out of New South Wales last year, that this is having an impact, and there is confusion out there as to the liability, what is an employment relationship. I've had this conversation with the AMAQ. There is clearly confusion as to what is an employment arrangement and what isn't, and so consequently who is liable for the tax. So this will give them time to work out, to get clear advice of what is an employment relationship and what structures fall outside of that. But I think it's important that the public understand this is not going to fix the GP shortage problem across the state and across the country. We saw early this year GPs stop bulk billing in a lot of areas, including my local area where there's no more bulk billing. Now, $80 for a telehealth appointment up front is really difficult. I am worried for my community. I am worried for people of Queensland who can't afford to find that money up front to have a doctor's appointment, either face-to-face or telehealth, even though they're getting some rebate from that, because if they stop seeking out health care at that early stage, they will end up in our EDs, and it could be that they've left it to such a state that they are now chronically unwell and need long stays in our hospital beds, and that's how we end up with bed blocks. So, I am concerned. This doesn't fix the GP shortage. This doesn't fix the bulk billing problem, but it does address one situation that was out there that was particularly concerning GPs. We've got a lot of work to still work with these doctors, work with the universities, work with the colleges about the number of medical places being offered. We need more medical places. We need to take more students. We need to accept more graduates. And I'm very proud of being part of a government that has just had an historic intake of intern doctors. And if I can go back to your question that you asked, Beth, you know, shouldn't we have been planning this 5 years ago? It was 2015 that the Palaszczuk government came in and announced they were going to employ nurse navigators and trial that, and in 2017 made those positions permanent. It's the Palaszczuk government who committed to nurse to patient ratios. You know, it is the Palaszczuk government that has announced the biggest investment in capital this state has ever seen to increase our bed capacity, the biggest intake we've seen in doctors, and we're increasing our nurses and midwives graduate program by 50% over the next couple of years. So we are doing the investment. These are long-term problems that have been significantly disrupted due to COVID. And the most recent reports we've seen, you know, the report on government services and health across the country shows that every single jurisdiction's been impacted by COVID and by these pressures.
To clarify, around Medicare.
Yeah, I was actually referring to the federal.
Yeah.
I wasn't referring
Yeah.
to
Not a state
No,
issue.
and it is.
Medicare's 40, should it maybe have got to 30 and changed?
Yes, we should have hit the 50-50, and it shouldn't have been frozen over the last 10 years. And we knew we were going to have a doctors' shortage with COVID and not being able to supplement our workforce with international doctors. All of those things, over the last 3 years.
Just on the Productivity Commission report statistics, there was some around sentinel events. I believe up until 2015, the state reported de-identified not where they were but what happened, and that was taken away by the Newman government. Would the Palaszczuk government consider bringing that back, and why not?
Look, I would consider that if the clinical advice I'm getting is such that even though when you say de-identified, you're not naming names, these figures are so small. When you talk about one death, when you talk about 2 incidents in certain categories, they can be identified in their local community because they know that that person was the one person they know about. So there is still those risks of identification. I think what's important is saying this is what's happened. It spells out the categories. It identifies, that these things have occurred. In a perfect world, would never have errors, but at the end of the day, it's human beings making decisions. And errors can occur, and the whole idea of these sentinel reports is to track this, to learn from it. Where it needs to go to a coronial investigation, it does. If someone needs to be held accountable, then they are by their, the relevant regulatory bodies.
Queensland was the only state that had a wrong procedure performed causing harm or death. Is that unacceptable?
Oh, it's concerning, of course. But as I say, you've got a staff of around 120,000. We have over 1 million presentations a year in our DEDs. We have thousands of operations every year when it comes to emergency and planned care. And in a perfect world, you would say there should never be a mistake. But mistakes happen. And we've got to learn from those mistakes. And that's why these reports are very, very important. And that is why that there has to be transparency around, if there needs to be an investigation, whether there needs to be an investigation by the regulatory bodies and whether there needs to be any action taken around those people's accreditation. That should happen. And that's why, all of this is important. But I do want to also, and in no way take away from those sentinel events reporting, the reporting about Queensland's data, and the response times in EDs and ambulances. I think it's important to put some context around this, that even though we've seen, declines or targets not being met, Queensland is performing very well across the country. And I think that's really important to acknowledge. We have the second highest number of emergency department presentations in the country, and we have the second best rate of seen-in performance time in our EDs. That's extraordinary. We have only New South Wales is outperforming us in that regard. We have the busiest ambulance service in the country, 230 incidents per 1,000. In contrast, New South Wales has 126 per 1,000. Now, much of that's because we have a free ambulance service. And our response times, yes, it's 24.9 minutes response time on average across the state. And when we talk about that, we should acknowledge New South Wales is 36.8, Victoria's 26.6. So, you know, we are performing well. When we look at the national statistics, we're all facing the same challenges, but yet Queensland is performing exceptionally well in the context of all of those challenges. And I do want to acknowledge that, because what our staff hear every day in the media makes them feel demoralised. They feel like they're just constantly criticised, that they're not performing well enough. And they are doing extremely well in challenging times, with demands that are just ever increasing. And I do want to acknowledge that, because you know, they deserve praise and recognition for the great work that they are doing. And this latest data shows that we are performing, you know, extremely well and high up there when it comes to compared to our other large jurisdictions in this country.
This is just back on the GP Payroll Tax.
Yes.
GP's going to keep pushing for a full exemption, not just the 2.5 years. Do they have your support in that ongoing campaign?
Well, look, those are conversations and decisions made by Treasury and led by Treasury. But I think that what the Treasurer has put forward is a very sensible solution to dealing with the challenges that we have before us right now. 2.5 years for GPs and medical practices to restructure their organisations so that they are not liable for this tax, which in fact gives them that exemption if that's the way they choose to structure their business.
Is this not just delaying it for the issue until after the next state election?
No, it's a sensible solution to allow these businesses to look at their own structure, seek advice on what is an employment arrangement and how they can structure. If they don't want it to be an employment arrangement, then how they can structure their business to not be liable for that tax.
Can I just confirm, I know you spoke generally about those sentinel events. Does that mean that one wrong procedure that resulted in serious harm or death was investigated, or generally they all are, if it's that still?
Look, as they're sentinel events, my understanding is they would all be investigated. Yeah.
Okay, great, thank you.
Well, good. Thank you.